Assistant Consultant in National Guard Hospital, Jeddah. Thank you for inviting me today. I will start with our objective. We're gonna tackle a few points about the leak post sleeve gastrectomy and the esophageal stent. We're gonna present our case, and we will discuss some of the review of the literature. Leak post-sleeve gastrectomy occurs around 2.4 post-gastric sleeve, and the most common site is the gastroesophageal junction. It reaches up to 85%. The causes of leak are vary between technical errors, stable line leak, poor vascularization, and gastric inflammation. And one of the most contributing factors is the increased intraluminal pressure post-sleeve. Usually, the first step post-sleeve gastrectomy leak to start the patient on MPO, adequate drainage of the collection, nutritional support, and covering with antibiotic. The patient usually, when they go through conservative management leak, liberal use of CT scan and gastroesophageal swallow to follow up the anatomic location and the severity, also with the containment of the leak, can be used liberal. The operative intervention usually indicated when there is a failure of conservative management, deterioration of clinical situation. Endoscopic stenting become a key point in the management of stable line leak, because the success rate in the literature mentioned was up to 80 to 94%. Usually we use the covered self-expandable metallic stent, which is designed for the bariatric patient. When we want to follow up the stent after the insertion, assessing the drain output, resolution of the leukocytosis, and continuous re-imaging to ensure the closure and the stent position. Although the stent are very successful, but they are not without complication. There is an early and late complication. The early, such as the pain, perforation, and bleeding. The late complications are more common. Mainly the migration happens around 40%, and it's more common now in the era of covered stent. The other rare late complication is the aorto-esophageal fistula, which is our scope in our presentation today. Our patient was a 34-year-old military man, medically and surgically free, presented to our clinic with a BMI of 48.2. He went through the pre-surgery protocol, which is including upper GI scope to rule out any esophageal and gastric abnormality. Then he went through an ultrasound abdomen to rule out gallstone, routine lab works done. Then the patient was ready for the procedure after the consultation to the dietitian to start him on pre-operative diet plan, which is low calorie and high protein. Patient went to the procedure, sleeve gastrectomy was done, and it was uneventful on October 2015. Day one post-op, the patient was doing well, tolerating orally after the gastrographene swallow. It was done and showed no leak and no hold-up. He went home after the discharge with a follow-up plan, which is 2 weeks in the clinic, 2 months, and then 6 months. All his clinic visits were, there is no complaint, patient was tolerating, no abdominal pain. 9 months post the sleeve gastrectomy, patient went to a local hospital with a complaint of abdominal pain and nausea and vomiting. There was a suspicion of perforated DU, and patient contacted the bariatric team in our hospital, and we recommend to come back to the ER. In the ER, patient was investigated, CT scan was done, and showed stable line leak at the site of the gastroesophageal junction. At that time, after stabilization of the patient, the decision was to take him to laparoscopic exploration. During the exploration, there was a collection at the gastroesophageal junction. It was drained, and another drain was left there. We decided to do a jejunostomy feeding tube for post-operative nutrition Then post the procedure, patient went to the endoscopy and covered stent was inserted. Post-op, few days, patient started to tolerate orally and continue on jejunostomy feeding tube and discharged home in good condition. Those are pictures showing the site of the leak at the gastroesophageal junction. 6 weeks later, patient came back to our hospital to just remove and reinsert another stent. At that time, the stent was already migrated, and then he went back to his daily life. 1 month later, patient presented to the ER with a complaint of upper GI bleed, hematemesis, hematochezia, and he had 2 attacks of syncope. When he presented, his hemoglobin was 5. The ER contacted the primary team, and the decision was by the ER to take him for upper GI endoscopy to rule out bleeding perforated peptic ulcer, but the team decided to hold the procedure and take him for CT angio to rule out aorto-esophageal fistula. CT done showed communication between the esophagus and the aorta at the level of the gastroesophageal junction and migrated stent. Those also the same CT scan showed the migrated stent. After stabilizing the patient, we decided to send him for a vascular surgeon for aortic stent insertion. Aortic stent was inserted, patient shifted back to the ICU, stabilization continuous, and after a few days, when we imaged the patient, the stent continued to migrate and reach up to the pylorus. At that time, we decided to remove the stent surgically because it was difficult to the endoscopist, and there was future plan for definitive surgical management for this fistula. But at that time, the tissue was inflamed and angry, and the patient was not ready for a definitive treatment. After that, the patient discharged home and continued to follow up in our clinic regularly with upper GI studies. On July 2017, there was a gastrographin study was done and showed no evidence of leak. So this is the last image done for him, showed that there is no communication anymore between the area of the leak. We reviewed the literature regarding the aorto-esophageal fistula. The mortality rate is high, up to 77 with intervention and up to 100% without intervention. There is 2 types. The primary is rare, and it happens post-thoracic aortic aneurysm, foreign bodies, and esophageal malignancies. The secondary one is more common and usually happen after aortic or esophageal surgeries and graft placement. It's one of the life-threatening condition, and it's been described on 1818, and it was a very lethal condition by Dubreuil, and also Kayari described it in 1862. He described a triad to diagnose an aorto-esophageal fistula, which is mid-thoracic pain, hurled hemorrhage, fatal hematemesis. The management strategy for those type of fistulas are varied between bridging thoracic endovascular aortic repair, 1-stage resection surgery, extra anatomical bypass, and conservative management. When we reviewed the literature, there was no much of cases of aorto-esophageal fistula post-bariatric surgery like sleeve. The first described case was, the paper was published in World Journal of Gastrointestinal Surgery by Dr. Bamehriz and Dr. Madi and Dr. Al-Jabreen. It was about a patient, published in 2013, about a patient post-gastric sleeve complicated by leak, and stent, self-expandable stent was inserted. 7 weeks post the stent, patient presented with severe upper GI bleed. Investigation was done for him and showed no site of bleeding, including CT angio and upper GI scope. So the patient was in shock while in the presentation, so they decided to take him for laparotomy. During the laparotomy, they opened the stomach. They found a pinpoint area of bleeding at the GE junction, and they discovered the aorto-esophageal fistula, so they decided to take him for a thoracotomy. Thoracotomy was done, but unfortunately, patient did not survive the procedure. The other paper was written by Takahiro Yamazato, and it was published in 2018 about the surgical strategy for the treatment of aorto-esophageal fistula. They described 27 patients with aorto-esophageal fistula secondary to an aortic lesion and aortic surgery. And their conclusion was that the stage surgery consisting of resection of an aneurysm and the esophagus in situ with the reconstruction of the descending aorta and omental flap, it's the best outcome comes with those type of procedure, the aggressive treatment. Although if the patient, while presentation, he was unstable, they recommended to take him for thoracic endovascular aortic repair and for further later reconstruction if he survived the first procedure. Last one was about the new insight regarding the incidence, presentation, and treatment of aorto-esophageal fistula after thoracic endovascular aortic repair. Was published in Cardiothoracic Surgery Journal of European Registry, and it they studied 36 patients post-aortic surgery, developed aorto-esophageal fistula, and they followed them for 90 days. They classified their group for 4 groups. The first one, they treated them just conservative, and the mortality rate in 1 year was 100%. The second group was the esophageal stent group, and survival rate was 17% in 1 year. The third group was the isolated esophagectomy group, and the survival rate was 43% in 1 year. The last group, which had the best outcome, is the radical esophagectomy and extensive aortic reconstruction. The percentage was 46% survival in 1 year. We concluded that because of the lack of evidence in the standard treatment in aorto-esophageal fistula post-sleeve gastrectomy leak, the treatment of those patients depends on the clinical situation at that time. Our approach was endoscopic intervention with insertion of esophageal and aortic stenting with a regular follow-up by CT scan. Because the patient at that time was clinically stable, doing well, tolerating, we decided not to go further with a definitive surgical intervention. Now we are following the patient for 2 years, and he's doing well. So this was our management. Thank you, and thank you to my team.
Thank you very much, Dr. Ghalia. Any question or comment from the audience?
Dr. Ghalia, if you'd allow me for a question, for the use of stent in chronic leak. This patient presented with a leak on 9 months, right?
Yes,
9 months out. So what is the chance that this leak can be treated successfully with endoscopically placed stent?
I think Dr. Tarik can answer this better than me. Okay.
Yes, I understand and I agree with you. Chronic leak is going to be unlikely to respond to stenting. We don't know if this is a chronic leak or this is a delayed leak. Okay, the delayed leak is probably not an entity that is agreed upon, but it is being described. This patient, as mentioned in the presentation, who was seen regularly in the clinic, and follow-up was perfect and complete till the episode occurred. So we will have no evidence that this leak is a leak that has been there and not resolving. This is something has occurred, and we don't have an exact timing for its occurrence. We still, because of that, we had cases that had leak that were not responding to treatment, then we have surgical options. But because of the situation here, we elected to go to the stabilization phase, including the stenting. Actually, it worked eventually, as you can tell. I just want to correct one thing, that the treatment was initially, stent was there, the treatment was aortic stenting, not esophageal stenting, because the stent was in place. The stent, obviously, in the aorta will not be removed. Our plan was to remove the stent. We elected not to remove it immediately because of we did not want to shake the stable situation in the area of the leak. When we decided to remove the leak, remove the stent, at the time of the removal, we discovered that the stent has continued to migrate downward. Our option that was discussed with the patient is to go for a total gastrectomy. Understanding the area will be very inflamed, we felt the situation might not be ideal and the risk is too high, so we elected to temporize the condition. It happened that the plan was still on schedule, and we elected to give it more time. I would say, luckily enough, on the follow-up, the leak started to shrink till it was completely closed. We followed the patient endoscopically later on, and initially radiologically repeatedly, and it's been more than 2 years now, and the leak is closed. So I guess we cannot just fight success, so we're happy with the outcome.
Was this patient a smoker? Because smokers can present with delayed leak. So was this patient smoker?
I can't remember, but...
And second thing is what I want to comment about the long stent which we usually use. Then nowadays we get a smaller stent which is called beta stent, having 2 dumbbells on both sides, and it's hardly 6-7 centimeter. So that can be placed at the site of leak. For acute leak, it is the preferred stent. I don't know about the chronic or long-standing leak which present after.
I agree with you. We had experience with migration, probably more with the smaller stents. The stents that with our limited experience that we felt that will stay in place are the mega stent with long passing the pylorus. Still, we had cases of migration, but I think from our experience it is less. We use the short stent maybe on a mini bypass or on
short stents. Straight stents will definitely migrate, but the new stent which has come up is having a beta stent which is having dumbbell shape on both sides, which will not allow it to migrate.
We don't have experience with.
So that is a new stent I think we can try.
Yeah. But commenting on the, we had patients who were referred to us from outside with the stent after stent after stent, and I agree with you 100%. Just you have a window of opportunity. If it doesn't work, it won't work. So those people who get stent repeatedly changed, they do as well as without stent, I guess. And this patient did well without stent.
Certainly, this is not a common scenario. To have a patient who comes for the first time with problems at 9 months is not something that we see on daily basis, and it is where the art comes more than science. So trying the stent is one modality, one way to go, but here we had to pay a price for the fistula, the Aorto-Esophageal Fistula. The other thing is what exactly happened in this patient, that we ended up with not sealing the leak, but converting it to a contained leak. So there is a small cavity, and it is asymptomatic, and life goes on.
Yeah, the cavity is continuously shrinking, and we have cases we treated conservatively, and we accepted that the cavity is contained. But in the follow-up, we do measure actually the size of the cavity till it totally disappears. And in the endoscopy, when you follow down with the endoscopy, you can barely see a dimple on the side of that. So there is going to be total contraction and epithelialization, which is in a way is healing. The message I wanted, maybe the message of Dr. Ghalia's presentation, is that just addressing the fact that this entity we never had a leak, we never had an aorto-esophageal fistula, but in our training we had aorto-duodenal fistulas, and at least in my training I've seen a lot, or I've seen some, I would say, and the same concept, the fact that alerted us to the possibility of having this is the lack of history. This is a sudden bleeding, very brisk and massive bleeding to the point that the patient became in shock, 5 grams, and it's stopped. It's a classical herald bleeding. If this patient had a scope at that time as scheduled, probably he would have died. So I mean, the message to send for people that this is something that is there, and it's very important that you know that something to put in your mind when you have a similar situation. It happened with Dr. Bamahrez, apparently. It happened to us. And the other thing, surgical intervention acutely is not good at all.
Perfect. Thank you very much. Yeah, one more question, Prof.
Esophageal fistula is not common thing, especially with the stent. It's not something which you're going to see every day. So many stents are put now for leaks and for other things and twists, but you don't see this thing. But it can happen. It is very